Good morning, everybody, and thanks for joining us today. We'll likely have a few more people filtering in shortly, but in the interest of keeping on time, we will get started for those of you who are here nice and punctually. My name is Kim Cowan. I'm a project lead with SEARCH, which is the Centre for Excellence in Rural Sexual Health for anyone not familiar. I work out of Shepparton, but we also have team members in Bendigo and Parkville. And it's my pleasure to welcome you all to the SEARCH Sexual Wellness PD webinar for August 2025. We host these PD webinars every month on a range of different sexual health topics, sometimes with a clinical focus, education, community, research, all sorts of different topics. So if you're interested, many of our previous webinars are available on YouTube. If you search for SEARCH SWPD, they're well worth a look. And then keep your eye out for the sessions that we still have coming up for the remainder of 2025. Before I go any further, I'd like to offer an acknowledgement of country. On behalf of the University of Melbourne and SEARCH, we would like to acknowledge the traditional owners of the lands on which we live, learn and work. Wherever we're zooming in from around Victoria and Australia today, we are on Aboriginal land, and we would like to pay our respects to elders past, present, and extend that respect to any First Nations colleagues who may be joining us today. Just a few housekeeping things before I introduce our speaker. So our session today will be around 60 minutes and we should have time for questions at the end. So if you think of any questions throughout the session, just drop them in the chat and we'll save them up for the end. And we're also recording this session, so you'll have the opportunity to rewatch it or share it with friends or colleagues who couldn't join us today. So without further ado, it's my pleasure to introduce our speaker for today, Professor Bronwyn Graham. Professor Graham is the Director of the Centre for Sex and Gender Equity in Health and Medicine at the George Institute for Global Health and a Professor in the School of Psychology at UNSW Sydney. Bronwyn is a behavioural neuroscientist, a clinical psychologist and a globally recognised expert in women's mental health. Bronwyn leads an interdisciplinary research team that examines how female unique factors like fluctuating sex hormones over the menstrual cycle and pregnancy impact the development of anxiety and other affective disorders. She employs a bench-to-bedside translational methodology in which she investigates endocrine regulation of the brain and behaviour in preclinical studies and then tests the application of these findings in clinical populations. Her work has led to new practice guidelines for treating anxiety disorders in women and RACGP accredited training programs for mental health care professionals. Bronwyn has held numerous fellowships, including an Australian Research Council Discovery Early Career Research Award, a UK-based MQ fellowship, and an American Australian Association Neurological fellowship. She is Chief Investigator on multiple Australian Research Council Discovery projects, an NHMRC Centre of Research Excellence, and a Wellcome Trust Mental Health Award recipient. She's published over 75 peer-reviewed articles and chapters and has supervised over 40 honours and postgraduate students. So with such an extraordinary breadth of expertise and impact, we're truly fortunate to have Professor Graham with us here today, her presentation is titled Accounting for Sex and Gender in Health and Medical Research and Practice. Why does it matter and where do I begin? And thank you and welcome, Bronwyn.
Thank you so much, Kim, for that lovely introduction. It is so great to be here and appreciate also the acknowledgement of country. I am coming to you today from Bidjigal land. So before we get started, what I would like to do is set some definitions. I'm sure that being amongst an audience of experts in sexual health, everybody is very familiar with the terms sex and gender and the differences between them, but it's always nice to just make sure that everybody's on the same page because these are terms that I'm going to be using a lot today. So although sex and gender are often used interchangeably, they are actually distinct terms. Sex refers to a set of biological attributes, including gonads, chromosomes, genitals, hormones. These sets of characteristics vary within males and females. And although sex is classed as male or female, there are a proportion of people who are born with innate variations of sex characteristics that don't fit into the medical norms for male and female. Gender is a sociocultural construct. and it refers to people's identity, but also their ways of expressing themselves, their behaviours, their experiences in a gendered society. And gender is not a binary term. It doesn't just fall into girls and boys, men and women. There are a range of different gender identities and expressions that people adopt. And gender is influenced by culture. It changes across time and place. So having established those terms that I'm going to be referring to today, I now want everyone to just have a bit of a thought experiment. And so I want you to imagine, I know we've got some health professionals in the audience here, but I want you to put yourself in the position of the patient. And think about the last time that you visited a health professional for any particular health condition and received a treatment or a recommendation. And I want you to think about some of the assumptions that you made when you were receiving that treatment. So if you're like most people, you would probably assume that the treatment that you're receiving is evidence-based, it's been shown to be safe, and it's been shown to be effective, and that the reason that we know that is because it's been tested in scientific studies on someone who looks sort of like you, right? Who kind of resembles you. And so, you know, we feel pretty safe receiving those treatments because of that. And while that is, you know, by and large true, I don't want to kind of be alarmist here and suggest that the treatments that people are receiving are not evidence-based. Those of us who are researchers in the audience will know that that's not exactly the way that it works, that in science, we test out the effectiveness of treatments on models and on data sets that we really try to make resemble the wider population that who are going to be receiving these treatments, but don't necessarily cover all of the different ways that people can differ. We expect that the results from those models will translate, will generalize to the broader population that is receiving those interventions. And because of the way that we work in science, we have developed some blind spots in terms of how representative our models and the populations that we study are. And there's many different blind spots, but the one that I want to focus on today is sex and gender. So in 2011, a meta-analysis came out that looked at studies in the areas of neuroscience and biomedical research. So really, really broad range of studies here. And these were studies that came out in 2009. And this particular study looked at, or this particular meta-analysis looked at whether or not males and females were included in the data. So these graphs that are depicted here are animal studies. And so what you can see, sorry, that's figure A at the top. What you can see is that for the animal studies, for the vast majority of fields, there was a male bias evident. Males were being studied more frequently than females. And the only exceptions to this were studies in reproduction, the areas of reproduction, and immunology. But of course, the vast majority of studies in immunology didn't actually specify the sex. So we don't even know what sex is actually being studied here. Now, if you look at the human studies, you can see that by and large, human work is doing a lot better, a lot more, a greater proportion of the work is including both sexes. But still, where there is a bias, the evidence is that there's this male bias, that we're studying males more frequently than we are females, again, with the exceptions predominantly being in the areas of reproduction. Now, this bias in the sample selection for particularly preclinical studies, but also for human studies, has been shown in many, many different areas of research and many, many different studies. But I think this meta-analysis paints the picture really well. Now, the other issue, which I alluded to, is that in addition to sort of not having some studies where they say they haven't actually specified the sex of the sample, there's also this issue that a lot of studies are not actually analysing the results disaggregated by sex, right? So even when they have included both male and female participants or subjects, the vast majority of areas of studies from different fields of practice are not actually analysing the results and testing for sex differences. So what this means is that if there are sex differences in outcomes, the research is not actually going to be able to pick that up because they're averaging the results across sex. So one of the more sort of perverse aspects of this bias is that the bias is actually even evident for medical conditions that are more prominent in women than men. So I'm going to take you through a couple of case examples to illustrate that. And the first is pain. So chronic pain conditions and different kinds of pain conditions, by and large, are more prevalent and pose a greater burden in women relative to men. And that's, you know, really well established across a whole range of different pain conditions. Despite that, if you look at the proportion of studies conducted in animals published in the journal Pain, which is the best journal for pain research, what you can see is that there is this huge male bias, right? So the vast majority of studies are only conducted in male animals, and that really hasn't improved very much over time. The other example that I'll give you is anxiety disorders. So that's my area of research. Anxiety disorders are a huge problem for everyone, but they are more prevalent in women relative to men. And we see this basically across almost the entire lifespan, where women are 1.5 to 2 times more likely to be diagnosed with an anxiety disorder relative to men. But despite that, this is a meta-analysis that we did in the studies of fear, stress, and anxiety, again in rodents, conducted in the year 2021. 2/3 of all of the work in that area was only conducted in males. Okay, so females are only being included in about 1/3 of the work on fear, stress, and anxiety, despite being more likely to require treatment for an anxiety disorder. And so, yes, that's animal studies. What about human studies and clinical trials? So for many years, women of reproductive age were banned from participating in clinical trials, which was a really unfortunate consequence of the thalidomide crisis. There were fears that if we included women of reproductive age, then we could inadvertently harm a potential fetus. And so while that policy was overturned in the 1990s, there has been a bit of a hangover effect for that. So for many years, clinical trials were predominantly males. Now things with policy changes, the male-female participation has evened up, but we're still seeing in contemporary clinical trials that are being conducted that there is a greater proportion of males relative to females, even for conditions where females are overrepresented, like in psychiatry clinical trials. Or conditions that are women's biggest killers, like cardiovascular disease. There's this underrepresentation of women. And as I said, there is still also this issue that even though, by and large, most clinical trials do include both sexes, the results are typically not disaggregated according to sex. So we're not picking up those sex differences if they exist. So what I am trying to say is that while, you know, we do the best job that we can in terms of developing the evidence base for the treatments that we are offering people, Our current evidence base is really just capturing the tip of the iceberg in terms of population representativeness. Women have been very much underrepresented in research. And then if we turn to marginalised sex and gender groups like trans, gender diverse people, people who are born with innate variations in sex characteristics, we find really, really lacking good evidence base for healthcare treatments. So we've got some problems in our evidence base. But why is this the case, right? So why are women being excluded from research? So there's this idea that the inclusion of females in data is mad, bad, and potentially dangerous. As scientists, we want to have data sets that have as little variability as possible, right? We want really kind of homogeneous groups so that if we're looking at the effect of a treatment, we have a really good chance of detecting that that treatment has an effect relative to the placebo. And the way that you do that is to really reduce your inherent variability in your data set. And so there is this view that because females have hormones that cycle across the lifespan for different reasons, menstrual cycle, changes with pregnancy, changes with perimenopause, that their inclusion is going to make the data set too variable, right? And so these are some sort of summary statements for reasons that I've seen repeatedly throughout different studies as to why females were excluded. So for instance, only male rats were studied to avoid inconsistencies in data due to the female estrous cycle. So that's the rat version of the menstrual cycle. Pregnant women were excluded from participation to avoid potential harm resulting from the stimulus. In this case, the stimulus was a loud noise. So I'm not sure, I certainly don't think that a loud noise during pregnancy is a potential risk, but nonetheless, that's the reason given. And so therefore we don't get any information about pregnant people in that study. Or there are kind of conditions set on women's participation. Women were permitted in the study provided they were taking a hormonal contraceptive to ensure stable hormone levels. So we don't want anyone who's naturally cycling because their wacky hormone levels might impact the data. And, I think that hopefully everybody can see that these reasons probably don't sort of stand the logic test. For one of the reasons being that, well, males also have hormones. Males also have hormones that cycle, right? They change across the day and across the lifespan. And we're not putting these kind of impositions on males to justify their inclusion in the study. So these aren't great reasons for excluding women from studies, but nonetheless, historically, this is what has been the case, and this continues on. And as I mentioned, there's also this fear of potentially harming a fetus, but often that fear gets overblown. But does it matter, right? Does it matter? Is it the case that males and females are so different that we can't actually take what we've learnt about a particular treatment from the male body and apply it to the female body and have those effects kind of apply fairly well? Well, my argument is that, yeah, it does matter, actually. For one, we can't actually study female-specific health conditions in male bodies. It just doesn't work. And so that means that we're missing out on information on a whole lot of female-specific health conditions. And we see the impact of that play out in terms of things like that it still takes about 7 years to get diagnosed with endometriosis. But this is also relevant for health conditions that impact everyone, irrespective of their health, irrespective of their sex or gender. And so I want to give you just 3 examples of how sex and gender can be relevant for health conditions that impact everyone. And the first of those is asthma. right? So fairly common respiratory condition. Now, early in life, the prevalence of asthma is greater in boys than in girls. And we think that that is due to sex differences in the physiological development of the lungs, right? So there's a sex influence on the prevalence discrepancy there. But then later in life, post-puberty, that prevalence flips and asthma becomes more prevalent in women than men. And we know that in part that's due to the influence of cycling hormones on asthma symptoms, right? So for many people, you see this menstrual related change in asthma symptoms, and that's probably due to the effects of cycling hormones on inflammation. But gender also plays a role, because we know that there are particular occupations that men and women are more likely to go into that confer different environmental risks for asthma. For instance, women more likely to be going into hair salons, nail salons, right, that have the dust and the particles that can increase risk for asthma. Males more likely to be working on construction sites which have different environmental risks. So both sex and gender are relevant here to understand how the risk for asthma plays out across the lifespan. What about mental illness, and in particular anxiety disorders, which are the leading cause of burden for women across the lifespan? Well, of course, women's greater risk for anxiety is very likely in part to be driven by environmental factors, right? Exposure to certain traumas and stresses at a greater rate. Sexual assault is associated with a higher risk of developing an anxiety disorder. Gender inequities in domestic burdens, and I could go on. But it's also possible that this difference is due to underreporting of anxiety symptoms in males because of gendered expectations about what it means to be a man, and the disproportionate impact of mental illness stigma on men. But we also know that sex plays a role, right? Because we know that women's risk for anxiety disorders changes across the lifespan in tandem with hormonal changes. And so risk increases across pregnancy and the peripartum stage, as well as perimenopause. And symptoms of anxiety fluctuate over the menstrual cycle. So again, there are sex-specific influences to how anxiety plays out across the lifespan. And the final example I'll give you is with autoimmune conditions, which are 4 out of 5 cases are female. And just recently, scientists discovered that the exist gene, which is responsible for silencing one of the X chromosomes in XX females, is itself immunogenic and may in part account for women's greater risk to autoimmune conditions. But the exist gene only exists in females, right? And so that can't explain the risk for autoimmune conditions in males. And so we need to have a sex-specific approach to understand how autoimmune conditions play out differently in males and females. So those were just 3 examples. I could have given you hundreds. But what I'm hoping is that this paints this picture that when we're thinking about sex and gender influences on health, we're not just thinking about diseases that affect one sex or another. We're actually thinking about all health conditions and how sex and gender influence those health conditions in unique ways. And so what have been the consequences of ignoring sex and gender in our research base and therefore, our health practice? Well, many and varied. We know that women experience greater adverse drug reactions, both to drugs and vaccines relative to men. In fact, they're 1.5 times more likely to report these adverse drug reactions. A very well documented example, which I'm sure you've all heard about, is the differences in stroke symptoms that males and females present with. which means that stroke symptoms in women are often under-recognised, and obviously when you're having a stroke, time is the most important factor. So if those stroke symptoms aren't recognised as stroke, women are less likely to be treated in the way that they need to be treated for stroke management, and so they are more likely to die from having a stroke than men. As I mentioned earlier, pregnant women, we don't like doing research on pregnant women, and I completely understand that there are difficulties in conducting studies in pregnant women. But sick women get pregnant and pregnant women get sick, and we have to be able to provide them with evidence-based healthcare. And so, at the very least, we could be looking at this in preclinical work, but we just don't do it. As I mentioned, women have been really underrepresented, but gender diverse people have been even more underrepresented. And so we know very little about the health of transgender people. We know that gender affirming care leads to better mental health outcomes. And we know that prior to this, mental health outcomes are worse. And that is about it. We are not looking at how to provide appropriate health care to transgender people for other health conditions, right? And the same goes for gender diverse people. And the same goes for people who are born with variations in sex characteristics. We don't collect the data. Often there is limited opportunity to participate in clinical trials if you fall into these groups, and it just means that we're missing that evidence base for these groups of people. And it's not all about women and sex and gender marginalised groups. This also impacts men, because while we are sort of looking at the male body as the status quo, we're still not actually looking at the male-specific factors that influence health conditions. And one of the most well-established sex differences is actually in life expectancy, not just end-of-life expectancy, but actually across every single age bracket. Females have a greater life expectancy than males. So health conditions that kill males, females survive these, have a greater survival rate. It does mean that they're then living the rest of their life with the consequences of that condition, but they are surviving at a greater rate than males. We don't know why that's the case. And it's probably, the $64 million question. If we were to look at this sex difference and understand it, we could potentially improve male survival rates and improve male life expectancy. So males are really missing out as well. Everybody loses when we don't take a sex and gender lens to health research and healthcare. So internationally, it has been recognised for quite some time that this is a massive issue, these biases, and policies have been introduced to correct those biases. The United States did introduce a policy in 2016. It does still stand, surprisingly. We try not to talk about that too much, but they have introduced a policy that sex as a biological variable must be incorporated into funding applications for National Institutes of Health. Canada predated the US with their policy. They've had a requirement that funders for health and medical research need to show how sex and gender has been taken into account at every stage of the research proposal. And the European Union has also had similar policies for quite some time. Where are we in Australia? Well, we're a little bit behind. Last year, the NHMRC released their statement on sex, gender, variations of sex characteristics, and sexual orientation in health and medical research. This is not a policy, it's not a mandate, It's a statement, but the statement is strongly encouraging all research that's funded through the NHMRC and the MRFF to take these variables into account. And the definitions of those variables are congruent with those of the Australian Bureau of Statistics, which is what I based my definitions on at the start of this talk. So what does it actually mean to consider sex and gender in research? What are we talking about? Are we talking about inclusion? Absolutely. You know, you can't start to get an evidence base for different sex and gender groups if you're not making active efforts to include them in the research. But obviously, inclusion is not enough. We also need to disaggregate the data and analyse the data according to those different sex and gender groups so that we can pick up on differences if they exist. Are we talking about women's reproductive health? Absolutely, we need more work on female-specific conditions. But as I've mentioned to you earlier, this goes beyond that to all health conditions. The operative words in the NHMRC statement is all research and considers, right? So we're talking about every single health condition, and we're talking about considers. That is, give deep thought to how sex and gender might be impacting the outcomes. Because the bottom line is that sex and gender do impact all health conditions, from prevalence, risk factors, symptom presentation, trajectory, prognosis, treatment response. And so when we talk about giving personalised healthcare, well, there's sort of no more basic individual difference than sex and gender, right? We all have a sex, we all have a gender. It's the cornerstone of personalised healthcare, and our evidence base really has to start reflecting this. So how do you actually do this? What I want to do is give you a bit of a case study, my own story, the journey of a reformed sex-biased researcher. So when I was doing my PhD, I was studying a thing called fear extinction. So fear extinction is a really important concept in anxiety disorders. It's the main way that we reduce our fear. And when you're receiving a treatment for anxiety, that's the main goal, right? To reduce fear. And so fear extinction has been studied for many, many, many decades. We have a really great model of how it works in the brain. We've been able to use that to improve treatments for anxiety disorders. And so we continue to look at this model in the lab and in humans because it's so, so relevant to the treatment of anxiety. But when I was doing my PhD, I was only looking at fear extinction in males. And the irony is that I was also training to be a clinical psychologist at that point. And so the vast majority of my clients were women. I was seeing all these women with anxiety disorders and then running down to the lab to put my male rats in a conditioning box to look at fear extinction. And I just didn't see that, oh, you know, there might be a problem here that I'm learning about this process in males, but everyone that I'm seeing in the clinic is a female. Until I got to Boston, so that's where that photo was taken. That's where I did my my postdoc, and I arrived in the middle of the most massive blizzard that they'd had in about 10 years. And my postdoc mentor, Mohammed Malad, said, I think we need to start looking at fear extinction in females. And so begrudgingly, I thought, all right, well, I'll do that. That's fine. And the first thing that we looked at was the menstrual cycle, or in rats, the estrous cycle. And what we found was that fear extinction actually fluctuated across the menstrual cycle in both rats and in humans. And we found that when rats and humans had high levels of sex hormones, they were actually really able to extinguish their fear really well. They showed like good, strong reductions in fear, and they were able to retain those over the long period of time. But when they had low levels of sex hormones, they weren't able to do this so well. They would show fear relapse over time. And so that led us to think, maybe these sex hormones are important for fear extinction. But of course, there's many reasons why people don't have a menstrual cycle. One of those reasons is the use of hormonal contraceptives, which chronically suppress endogenous synthesis of sex hormones at the same time as leading to high synthetic levels of hormones. And so we thought, well, we better look at fear extinction in rats and humans taking contraceptives. So we did that, and we found that actually fear extinction was impaired in people taking contraceptives. And we discovered that that was because of the suppression of estradiol levels in those rats and humans. And then we thought, well, so it's not just females that have estradiol, males have estradiol too. And in fact, many of the actions of testosterone are caused by its conversion to estradiol. So I wonder if males need sex hormones, and in particular estradiol, for fear extinction. And so we did a series of studies where we blocked that conversion of testosterone to estradiol in males. And we found, lo and behold, that that impaired fear extinction in males. So it's not just females that need sex hormones to extinguish, males do too. And we would never have thought to look at that in males because we don't equate sex hormones with males. We wouldn't have done that if we hadn't actually made that discovery in females to begin with. And then we thought, well, we better start translating some of this to the clinic. So when I got back to Australia, I started doing a series of clinical trials where we were looking at the effects of exposure therapy for anxiety disorders in women taking contraceptives or those at naturally cycling. So that's me there with the spiders on my face at the end of exposure therapy. We predominantly worked with women with spider phobia. And what we found was that the benefits of exposure therapy were actually reduced in women taking hormonal contraceptives, and that treatment was most effective when it was given to women at points of their menstrual cycle when they had elevated levels of sex hormones. So these findings, these basic sort of understanding of how sex hormones influence the brain, are translating from rats to humans in lab studies to clinical trials. And then we thought, well, okay, but pregnancy is this time where you're exposed to massive levels of hormones. Does that actually influence how you're able to regulate your fear? And we found that post-pregnancy, the neural mechanisms by which fear is regulated completely change. And we actually have no idea what the key brain structures are in the regulation of fear after you've had a baby. All we've been able to show is that they're not the same as in females prior to when you've had a baby or in males. They're totally different. So again, sort of taking into account the female unique factors across the lifespan really impact the reliability and the accuracy of our models. And then most recently, we've looked at adolescence, another time of dramatic hormonal change, and a time when people often start taking hormonal contraceptives. And so we looked at the impact of hormonal contraceptives on fear extinction given during adolescence. And we found that they actually impair fear extinction during adolescence, but also that those effects of the contraceptives on fear extinction extend even into adulthood, even after the adolescent has been removed from the contraceptive. So what I want to paint a picture here is that sex hormones, considering how sex might influence a health condition that is actually experienced by everyone, shows that there are really unique factors that come into play depending on whether or not a person is a male or a female. And our models are just not going to be accurate, and our treatment is not going to be as effective if we're not taking these factors into account. So in the last little bit, what I want to do is just go through what are some of the benefits. If you're sort of not already on board, what are some additional benefits to incorporating sex and gender considerations in health and medical research? Look, this is absolutely about an equity thing. We do want everybody to have equal access to equally evidence-based care, but also it's actually just about scientific rigor and reproducibility and research integrity. Science that takes sex and gender into account is better science. And as some case studies for how this has played out over the years, the classic example is with stem cell research. So stem cell research used to be conducted just with stem cells from any sex implanted into any sex of animal, and it wasn't taken track of as to the sex of the cell or the animal. And there were inconsistent results emerging until it was discovered that the stem cells from a female animal have more regenerative capacity than stem cells from a male animal, irrespective of the sex of the animal into which they are implanted. And once that was discovered, the stem cell field was really able to move forward because they were overcoming these issues with unreliable data. To give another example, going back to pain, there are huge sex differences in pain sensitivity, in analgesic sensitivity, but I think most interestingly, in the direction of the effect of particular treatments. So there are lots and lots of examples where a treatment has an effect in the male animal, but not in the female animal. And that kind of makes sense because if you're doing all of your work in males and then developing these treatments, they're not necessarily going to be tailored to the female body, which shows differences in pain sensitivity and analgesic sensitivity. So again, if you're not taking sex into account, you're not going to get reproducible results. And that is a big problem when you start to try and translate these into very big, very expensive clinical trials. This is the movement that is happening internationally. And so Australia is going to keep pace and continue to be a leader in science and healthcare. We have to start to implement our own standards and comply with those standards. And that website there is a great website that has documented all of the different places across the world that now require sex and gender analysis. And so you can go and see that. There's many places there where you can apply for your own funding. And so you're going to be missing out on opportunities to apply for international funding if you're not consistent with the standards that are being set internationally. With enormous knowledge gaps, the main benefit to, or the only benefit I would say, to our lack of knowledge on females and other sex and gender minority groups is that we have the potential to make huge knowledge gains because of how little we know. And when we make those gains, those knowledge gains, they are often really high impact discoveries. And one of my favorite examples of that is pregnancy. Been doing it for thousands and thousands of years, but it's only recently that we've thought to look at what does pregnancy do to the brain? Does it actually cause changes to the brain? And so over the past decade, a series of papers has come out looking at brain changes in pregnancy and establishing that there are these reliable reductions in grey matter volume that persist well after breastfeeding finishes. This particular study was an N=1 study, just one person that was scanned continuously across their pregnancy and tracking the different changes, the structural changes in the brain, published in Nature Neuroscience, mentioned in 278 news outlets. Who doesn't want that kind of opportunity for impact? And relatedly, the best journals in our field now have sex and gender policy. They are running sex and gender special issues. Again, you'll miss out on those opportunities if you don't do this kind of work. The femtech market, which is basically technology designed for women's health, has a huge market potential. So it's currently around 40 billion. and it's projected to more than double that by the year 2030. And so industry is starting to become aware that there is this huge gap in the market, and they are starting to invest. And obviously, as scientists and healthcare providers, we want to make sure that they're investing in appropriate evidence-based care. So we need to partner with them to make sure that they have that great evidence. And really, you know, it comes down to what we all care about, which is healthcare that takes sex and gender into account leads to better practice, and it saves lives. And this has recently been demonstrated in Canada, where specialist heart clinics for women have been introduced to account for the fact that often heart attacks are missed in women because they don't have obstructions that are being picked up in angiograms, and so they're sent away and they're not receiving the care that they need. And these specialist heart clinics that are trained to understand the differences in cardiovascular disease between males and females are leading to improved diagnosis, reduced burden on the hospital system, and better quality of life for women. So the final thing that I want to mention, if you are sort of feeling energized by this and wanting to do something about it, what I would encourage you all to do is think about your own spheres of influence and what levers are available for you to pull. And the philosophy that we take at the Centre for Sex and Gender Equity in Health and Medicine is a top-down and a bottom-up approach. We need policy, because without policy, there is no consistency or standards of practice. And so you have to have that overarching policy that requires everybody to take sex and gender into account. But policy on its own is ineffective, because you have to have the capacity of the workforce to understand, why does sex and gender matter, and how do I actually take it into account appropriately? So I would be encouraging you to think, does your organisation where you work have a sex and gender policy already? If not, can you get a working group together to develop one that's appropriate for the context of your work? If you do have a sex and gender policy, does it cover critical components? Because often sex and gender policies focus on workplace equity, who is doing the work, which is really important. But we're talking about, what is the work that is being produced? Is that equitable across sex and genders? And a policy is not effective if it's not actually implemented and audited, and if people aren't sort of held to account. So that's a really important thing to consider. And then, how can you participate in that capacity building? Do you have a role in education? Are sex and gender considerations a core learning outcome in the education that you're providing? We've recently been commissioned by the Federal Department of Health, Disability and Ageing to review all of the health and medical curricula nationally in Australia for sex and gender inclusion. We know that sex and gender are not core learning outcomes across the different areas of practice, so we don't expect there to be much consideration, but we will have that data by the end of the year, which will give us really important information for what needs to change in the education system. And are there opportunities to introduce training on the relevance of sex and gender within your work context, perhaps as continuing professional development? If all this sounds a bit overwhelming, help is available. We're here to support you. Please do reach out to us at the Centre. We love talking about this. We love helping organisations think about how they can better incorporate sex and gender. So you can sign up to the Centre mailing list here and get in contact with us at our website. There's amazing resources internationally. America has taken all of theirs down, but Canada still has their resources. The Intersex Human Rights Australia group is fantastic, as is Trans Health Australia and many, many others. And then finally, for additional inspiration, it's the Nature series that was published last year did a really great job at sort of stimulating thought-provoking articles on this area. And it was accompanied by a great podcast. So at the very least, I encourage you to have a listen to that podcast. And that is it from me. So thank you all for listening, and really happy to take any questions.
Thank you, Bronwyn. Wow, that was fascinating. I'll give people a minute to put your questions in the chat or take yourself off mute, and you can ask Bronwyn your questions if you have any. I really enjoyed your case study, Bronwyn. That was really interesting of just how much deeper you could go in that research once you started considering the differences there. I think your presentation has raised a whole lot of new questions for me of things that I hadn't thought about before.
Thanks, Kim. And I think that, the reason that I like to give that is that I think that there is this view that sex and gender considered work should be done in a particular way, and that it might stymie kind of intellectual freedom or the ability to follow your own areas of interest. And so I like to show that, to show that you can follow, whatever areas of interest that you want. And I haven't even touched on gender when it comes to anxiety at this stage. I'm still sort of bogged down in sex at this stage. But there is so much to look at, and there's so much sort of laterality in it.
Absolutely. And it's great to see some changes starting to come through, like in the international standards of research. Hopefully this space will look really different in years to come.
I hope so. I hope so. Australia is starting to, we're starting to see movements. We're starting to see changes in different organisations. But I think, as with many kind of movements in this space, we are a little bit behind. And I kind of liken the journey to the inclusion of lived experience in research. The UK was streets ahead of us in that regard. And now I think it's, much more embedded in Australian research and health practice. Still has a way to go. But I think the inclusion of sex and gender will follow a same sort of journey when it comes to those policy and practice changes.
Yeah, hopefully it'll be something we look back on, in decades, and we can't believe it wasn't included. If anybody is looking for copies of the slides from Bronwyn's presentation today, please just email the search admin email address and we can send those out to you. But as I said, we are recording, so it will be available to you on YouTube. I haven't had any questions come through, so which is fine. If no one has any, we can wrap it up. But thank you all for joining today, and thank you again, Bronwyn, for your presentation. It was really interesting.
Thanks very much, Kim. Thanks, everyone.
All right. Have a good day. I might sign off.
Thanks, Kim.
Thanks very much.